Welcome to Pediatric Zirconia Crowns Introduction to Implementation. I really appreciate all of you taking your time out of a busy Thursday. I think we have some of you on the East Coast around 8 o'clock, so maybe getting ready for bed, putting the kids down, and then some of you on the West Coast still driving home. So the goal is to not put any of you on the East Coast to sleep early, and for all of you on the West Coast to not fall asleep while you're stuck in traffic. So we'll try to keep this engaging, hopefully give you guys some useful tips and tricks. And for those of you who haven't implemented zirconia, hopefully we'll get you guys a little more comfortable with this and get you maybe more comfortable implementing it in your practice. And those of you who have, maybe we'll give you a couple good pearls and some things to take home and take to your practice and start implementing those for your patients. Quick little intro here about me. My name is Matt Lucero. Like Preston said, I'm a board certified pediatric dentist here in Denver, Colorado. If you are interested, you can follow me on Instagram at Dr. Matt in Denver. I try to post, useful little tips and tricks. I don't post too much. I'm kind of like a sporadic poster, so you might see some stuff here and there, but yeah, I just try to keep it useful and try to keep some things on there that people can use in their day-to-day practice. Quick little history on me, because we don't have a lot of time tonight, so I want to be brief. I went to Nova Southeastern University. I wanted to go somewhere where I wouldn't be distracted too much, so I picked the school closest to the beach and got totally distracted. But it was a great place to go to school for 4 years, learned a lot. Met lots of good friends, met my wife there, which was awesome. Then I did an AEGD at the VA hospital in San Antonio, which was awesome. I wanted to be like the jack of all trades, kind of Swiss Army knife general dentist, and ended up not being that in the end, but I learned a lot there. That's where I learned to be a dentist and really learned how to hone my craft and be a better dentist overall. I went out and practiced for 5 years total as a general dentist, and realized I didn't really want to do any of that stuff. And I did 2.5 years in public health, which is where I really learned that I love treating kids. And so I applied to and luckily got accepted to residency at OHSU, Oregon Health and Science University in Portland, Oregon. Spent a great couple years there. I loved Portland, loved Oregon. It's beautiful. If you guys ever get the chance, go visit, especially in the summer. It's amazing. But those winters out there in Oregon are a little gray, a little cloudy, a little cold and rainy. So my wife and I decided to go back to Austin, which is where I was practicing before. I started a practice there, sold that practice. Then I got a job here in Denver, which is where I am currently. And we love it up here. I'm outside a lot. Spend a lot of time in the mountains, spend a lot of time skiing. So if any of you are interested and want to come and hang out, you send me a message and I'll take you up skiing or take you up hiking or something fun this summer. So feel free to reach out. Quick disclosure, New Smile does provide financial support for these presentations, and they send us products to use and all that good stuff. Some of the images that you'll see are from other New Smile clinicians, and I'll credit those when it's appropriate. But I try to show mostly my cases because I kind of know the backgrounds on all of these, and I can walk you through some of my thinking when I'm doing these. So we'll go ahead and get started. I always like to start with the AAPD guidelines. These are like the holy grail of pediatric dentistry. These can back us up if anyone ever questions why we're doing what we're doing, especially when people start, kind of accusing pediatric dentists of overtreatment with full coverage restorations, which in my opinion, it's not overtreatment because most of the time we're preventing having to do treatment again. So if anything, we're preventing overtreatment. But parents ask us questions, insurances ask us questions, and so these can kind of back us up whenever anyone has a question of why we're doing what we're doing. So we'll go through these one at a time here. So full coronal restorations may be indicated when caries is present on multiple surfaces. And so that's what we see all the time when we're doing like mesial and distal decay on molars, when we're doing full coverage restorations, or we're doing interproximals on anteriors. It makes sense. They just work better in the long run typically. If the incisal edge is involved, that one for me is like almost an always. MIFLs and DIFLs on pediatric patients, they just don't work all that well. So full coverage, no matter what full coverage you decide to do, it always just works a bit better on those anterior restorations. If there's extensive cervical decalcification, and this one for me kind of applies when I'm seeing kiddos under general anesthesia or sedation or things like that, where we're going to crown 7 molars. The 8th one maybe doesn't have anything that's super obvious, but you got kind of that line of decalcification going around the gingival third. And it's like, do we want to just leave this and let it turn into a bigger cavity later, or do we just take care of it now? So those are the cases where usually I'll err towards putting a crown on that tooth rather than not. 4th is if pulpotherapy is indicated. For me, it's an always. And I know some people out there are more comfortable, doing like MOs and DOs with a pulp. especially on older kiddos, and they work. But for me, I just, I don't want to retreat things and I don't want failures. And so I just am more comfortable doing a full coverage restoration on those teeth. If caries is minor, but oral hygiene is really poor, and again, that kind of falls into that cervical decalcification type deal. If we're seeing a kid with severe early childhood caries and we're doing the treatment under general anesthesia, well, do we want to leave that eighth molar not crowned, or do we want to just leave things that we know are most likely going to get carious at some point in the future? So I usually like to lean more towards doing restoration on those teeth as well, more as a preventative type thing than anything else. If the child's behavior makes moisture control very difficult. And this one for me is kind of like the Hall Crown guideline. If we got a little guy, little girl, 2 or 3 years old, they have a big old occlusal on LNS that we know isn't into the pulp, but we don't necessarily want to, put them under general anesthesia or sedate them or anything like that. We can do a Hall Crown. We got moisture difficulty. Let's pop a crown on that thing, take care of it, and then we're good to go. So now that we talked about the reasons for doing full coverage restoration, let's talk about the different kinds that there are. So we've got some that are cemented to teeth with eluting cement, and this is my all-time favorite, and I probably would imagine most of our all-time favorites, the stainless steel crown. They just work. Like, that's the bottom line. These restorations just work. I don't think stainless steel crowns are going anywhere. We've got all these great options. We're going to talk about zirconia tonight. We've got BioFlex. We've got all of these great things available to us. And, the stainless steel crown is always going to be there because it just is functional and it lasts a long time. Open face crowns, and these are kind of an older style restoration, but the people who can do them are incredibly skilled. It's difficult to do. I think now that we have veneered SSCs and zirconia and all these other types of aesthetic restorations, we don't see these quite as much. But the folks back in the the 80s and 90s who only had stainless steel available to them, it took some skill to do these, but we don't see them quite as much anymore. Pre-veneered crowns, which is kind of what started New Smile back in the day. That's the signature crown from New Smile. I do a ton of these personally. I see a lot of high caries risk kiddos, Medicaid patients, and that's what's covered typically in most states. So if we're trying to do something aesthetic, that's what a lot of us end up doing. And I do tons and tons of them. They're a great restoration. I think New Smile's on the 7th generation of them, and some of the shortcomings that used to happen with these crowns don't happen quite as much anymore. And then monolithic zirconia, which we're going to get into a whole bunch here tonight. So I won't say too much about them just yet. And then we have crowns that are bonded to the teeth. We have strip crowns, which I think still have a really important place in pediatric dentistry. I do them on occasion. I try to limit them to kind of older kiddos that I don't need a ton of longevity from the restoration. 5-6-year-olds who maybe have some class 3s that I don't necessarily need to do a zirconia for or a signature crown for, and I just need to get those teeth to the finish line. I'll sometimes do them on lower incisors as well. Just teeth that I know aren't gonna take too much of a beating and don't need a lot of longevity. Pedo jackets and polycarbonate crowns are also some bonded restorations. We don't see these quite as much anymore because we have so many good aesthetic options. They lack some aesthetics and things like that. So just don't quite see them. I'm sure there's some people that still use them, but it's just not something that's too popular anymore. So I mentioned composites and strip crowns, and the downside to them is that they just don't have a lot of longevity. They're really beautiful restorations. I know when I do them, I'm really patting myself on the back and saying, wow, what a good job you did. And the parents love them initially, but we run into the same issues that we run into with like interproximal composites. We get breakdown, we get recurrent decay. With kiddos in the anterior, we get primary incisor wear. Kiddos have, non-nutritive habits where they're chewing on toys, chewing on fingernails, biting things that, they shouldn't be biting. And so we get some chipping and breaking of those restorations. And a lot of times when I'm doing strip crowns, I notice that, they kind of bind up towards the gingival third. And so we can get some exposed enamel still. And in kids that are, accumulating a lot of plaque and biofilm, you're still going to get decalcification in those areas, which eventually could lead to recurrent decay. And then the process of placing a strip crown, we have to keep the heme under control. We have to keep these teeth isolated. And a lot of times that's difficult as well. So we're not quite getting the correct bonding that we would hope to get with the resin crown as well. So you can see this photo from Dr. Larry Johnson. I really like this one because it really exemplifies what we worry about with strip crowns. You see all that breakdown, you see a little bit of decalcification, some chipping and wearing of the incisal edges. So all the things that we get concerned about, you can kind of see in that one image there. And this is a study that kind of backs that up. The study says, resin crowns are a reasonable restoration. They work pretty well, but in the long run, you start seeing deficiencies in function the longer that you see these restorations. So for me, like a 2 or 3-year-old probably isn't the right patient for a strip crown. As a kid gets older, then maybe that's a better option. But if I need 4 to 6 years out of a restoration, I'm not going to lean towards a resin crown over something else. So we'll get into zirconia crowns, which is a near and dear subject to my heart. This is one of my first cases that I ever did way back in the day. I took a restore course. Back in the day, it was called Progressive Aesthetics with New Smile. And I went back to my practice and I started doing these. And I wasn't quite as good at taking photos and documenting cases, so I only have an after of this one. But this one's near and dear to my heart. I think this is one of my first 3 cases I ever did. That's where I caught the bug. I just started wanting to do more and more of them. And I really fell in love with these restorations. So let's get into it. So there are some advantages and disadvantages of zirconia. It's not a perfect restoration. There are some things we need to look out for when we're using zirconia crowns, but advantages would be best aesthetics. These are really lifelike, beautiful restorations. The gloss on them is incredible. They're lifelike. We can do asymmetric cases where we're treating the right side but not the left side, and they blend in really well. They're really wonderful restorations. They're soft tissue compatible, and you'll see in some of the cases coming up how well the tissue responds to these restorations. These are materials that are used in other medical professions as well. So orthopedics, we get a lot of zirconia. So we know these are biocompatible, and they work really well. There's no metal show, obviously. This is a ceramic restoration, so we don't have the metal showing like we do with pre-veneered SSCs, where if you get a little rotation, you can see a little bit of metal showing. We don't have to deal with that. These are incredibly durable, and we'll go into a little bit more detail on the durability of zirconia as well. They're also great for crossbite. So if you have a crossbite case and you're not looking to open the child up or flare the anteriors at all, you can leave these in the crossbite and they're going to hold up really well. There's no nickel, obviously. These aren't stainless steel, so we don't have to worry about that for the small percentage of kiddos that really do have a true nickel allergy. Full coverage protection. Obviously, this is a crown, so we're going to get full coverage protection with it. Minimal chair time with practice. I know our first cases are not going to be minimal chair time. So we got to get some practice under our belts before we really get comfortable doing these quickly. And that's, a good reason to maybe consider taking a restore course. They're really fun. I would encourage you to come to one of our restore workshops and get some hands-on practice with these as well. They're autoclavable, and we'll talk about the try-in crowns and why we don't want to necessarily autoclave the white ones if we don't have to. And we have really good ways to avoid doing that. And this is a really important advantage, I think, for those of us who work in a hospital setting, residents, or docs that are teaching residency programs. For our special healthcare needs patients who get a lot of imaging, and especially head and neck imaging, that we don't want any distortion, no artifact with these images. These are really great. Where stainless steel crowns or a veneered SSC might give you some artifact that can alter that image. There are some disadvantages, however. You can't crimp these. So those of you who like to crimp the lingual of a veneered SSC, you're not going to be able to get that secondary retention, that mechanical retention with these crowns. And in fact, we really don't want any mechanical retention, and I'll talk to you about that here in a little bit as well. Saliva and hemorrhage have to be controlled. This is a ceramic restoration. If you have blood on the teeth, you're going to see some shadowing through that restoration. You also don't want it to be contaminated because you don't want to affect your bonding. So we'll talk about ways we can control hemorrhage as well. There's a learning curve. So like I said, it's not going to be quick right out of the gates, but the more of these that you do and the more comfortable you get with the prep, the faster you're going to get. This isn't exactly an SSC prep. It's going to be different. So it's a new procedure. So as we learn a new procedure, we have to practice it, and we'll get better and better as time goes on. And another downside is the cost. These are a little bit more expensive. They're $27.50 versus an SSC, which is around $4, or a veneered SSC, which is around $20-ish. But on the plus side, you usually will get better reimbursement for these as well. So we'll quickly talk about the scribing. So they use the Palmer notation at New Smile, which is kind of like what our ortho docs use. So we go by quadrant, then we go A, B, C, D, E as we go back, and then the size, and then they put the R or the L to represent the right or the left side. You can also remove these sizes. So if you get some of these parents who, they come in, their kiddo has decay all over the place, but suddenly they're worried about the dark mark on the lingual side of the tooth, and they're standing on their head to look up there and see it. We can take a fine diamond, buzz that size off the lingual, and we can avoid any issues with that as well. So what is the relevance of gloss on a zirconia surface? So we talked about the aesthetics of these zirconia restorations and the gloss that's applied to them. In general, the more glossy restoration is going to be a more aesthetic restoration. So when we're talking about different manufacturers of zirconia, there are different ways that they glaze these restorations. A lot of other manufacturers kind of do a hand glaze that's added to the surface during the creation of the crown, and it leads to inconsistencies. Whereas New Smile ZR, which we're going to talk about in a little bit more detail here coming up, it's a lot more highly polished due to the way that it's manufactured. These aren't hand brushed glazes. These are glazed during the process of fabrication. And a smoother surface leads to less plaque buildup. So not only are we using a zirconia restoration, which is really biocompatible to begin with, we also have a really glossy surface, which prevents the accumulation of a biofilm and plaque on the gingival third. It keeps that tooth easier to clean as well. And like I mentioned, more gloss equals more aesthetic. So glossier restoration is going to be a little bit prettier. And then we got less attrition to the opposing dentition as well. So when we're evaluating the gloss of a pediatric crown, there are studies that study this, and this study here used a Novo curve gloss meter, which I promise you exists. I Googled it just to see what it looks like, and I still don't know how it works exactly, but it's able to evaluate the gloss of different surfaces, not just dental crowns, but all kinds of surfaces, mirrors and everything else. So they put these crowns in this Novo curve gloss meter, and they basically just kind of tested how glossy these surfaces are. And you can see New Smile on the left, on the buccal and lingual, very, very glossy. And then those are competitor crowns there, Crown X, Crown Y. I don't know which competitors they are, but in general, New Smile was far more glossy than all the other competitors making zirconia crowns. The buccal, for some reason, not quite as glossy as the lingual, but still pretty darn glossy. But that just tells you, like, during the process of fabricating these crowns, New Smile maintains a very, very glossy surface, which leads to all those benefits we just talked about. So I talked about tissue attachment to zirconia as well, that we get really good biocompatibility with zirconia. This is a scanning electron microscope image of zirconia with soft tissue, and you can see how that soft tissue is adhering to that zirconia really, really well. And that's what we see with the gingival margin as well, is you get a really nice stippling, get a really healthy gingival response to these restorations. And this kind of photo exemplifies that. You can see how highly polished it is in comparison to those restorations next to it. If you take a look at those SSCs, we got a really heavy biofilm kind of accumulating that gingival third. We got red, kind of swollen gingiva, blunted papilla. And this is the same exact mouth. If you go one tooth over, you got a zirconia crown where you have a really highly glossed surface. You don't really have that plaque accumulation, that biofilm. You have a really stippled free gingival margin. And we have a really nice, thin, healthy papilla between C and D there. If you compare it to that lower canine, that even has a composite on the gingival third. You can see how rough that is, how you got a little bit more plaque accumulation if you look really closely. But just in general, these zirconias are going to get a much better tissue response. Even in a child that doesn't really have that great of oral hygiene, you're still going to get far less plaque accumulation and a healthier gingival response. And there's just a blown up photo of that same photo. You can really see all the detail there of how much better that gingival tissue looks than the adjacent teeth. So we talked about how pretty this restoration is. So there's got to be a downside, right? It's got to not be quite as strong as other restorations or even natural enamel. But if you look at this flexural strength, you know, New Smile ZR is far more strong than even enamel, which is the hardest material in our bodies. So we got a really polished, glossy aesthetic material, and we also have a very, very strong material. So there's a lot of really, really great benefits to zirconia when it comes to strength as well. They've also run some tests on this, even kind of after accelerated aging of the material. You can see how it holds up under a really heavy load. You can see they broke them into different groups there in this study, where they have one group that was before accelerated aging, which is that darker blue group, and then you have that lighter blue, which is after an accelerated aging, where they've autoclaved it and run it through an autoclave to kind of mimic an aging process on these crowns. And you can see just, you know, with 0 newtons for 0 cycles, they put it under a heavy pressure, and they would fracture it around 1,200 newtons, maybe a little over 1,000 newtons after it's been aged a bit. And then after they put it through 250 newtons for 3 million cycles, it still doesn't fracture until about 1,000 newtons of force. And if you see that line there at the bottom, that's the maximum biting force of a child. So if these are properly cemented, if the tooth is properly prepped, even under the maximum force that a child can force on that crown, you're not going to get a fracture of this material. It's just so strong. And here's another one here that kind of shows wear to opposing dentition. So, you know, you have a really strong material, so you would assume this is going to be something that's going to wear on the natural dentition, and it really doesn't. This is a study that was done with a Leinfelder machine, where they take these little zirconia pieces and they put natural enamel under a bunch of cycles kind of simulating 4 years of wear on a natural tooth. And you can see the wear that they found kind of falls into the normal range of what we would expect to see either way. So even with the zirconia restoration, a highly polished, glossy restoration, you're not going to get much wear to that opposing dentition. It falls into that normal wear pattern that we would expect to see. And these are photos from that same exact study there. You can see the enamel. They put it into kind of a resin, and then they would kind of poke it a million times with that little stylus tip on that Linefelder machine. And that's kind of the wear that we saw. So nothing more than what we would typically see, in a natural dentition, especially when we see some of our bruxing kiddos and things like that. They really beat up those teeth, even with their own natural dentition. And we just don't expect to see that with zirconia. So I talked about the manufacturing process. And the unique way that NuSmile makes these crowns is through a patented injection molding technique. And we'll kind of walk through that and compare and contrast that with how competitors make their crowns. So NuSmile makes their crowns kind of similar to the way like a gold crown is made, where you kind of mold that, you use a mold to create the crown. And so NuSmile has all these molds of all these different teeth and the sizes that they want to create. And they take a liquid zirconia and they inject it into that mold and make the crown. So with that, the benefits are that you can recreate that same crown over and over and over without any differences. So what that allows is for a really thin cervical margin. Because it's a liquid zirconia, you can put it into that mold and get really, really detailed crowns. You also get a really, really sandblasted intaglio surface, which we'll show you here in just a little bit as well. You get the exact same crown over and over, which also allows us to use try-in crowns, which we'll talk about in a little more detail as well. And it creates less waste. It's more cost effective. So NuSmile puts in that liquid zirconia. It makes that same crown. There's no waste involved with that. And so they can pass that savings along to us, the dentists who are purchasing these crowns. Whereas the competitors use a milled crown. So those of you who have used a CEREC, those of you who are general dentists and you use a CEREC currently, or those of us who have seen a CEREC, you take a zirconia block, you put it into a milling machine, it uses these little burrs, and it makes the crown out of that block. The downside to that is that there is a lot of waste with that. Everything that's outside of that block that isn't part of the crown is just waste. And the other downside is that we don't have as much detail that we can create with a burr as we can create when we're doing an injection molding technique. So you get a thicker margin of the crowns, whereas NuSmile is a 0.2 millimeter. With a milled technique, you can get about 0.5 millimeters, so a little bit thicker, more of an overhang circumferentially. The burr wear over time can lead to differences in the crowns as well, because your first crown is going to be a little bit different than your 100th crown, right? As burrs wear down, you get a little bit less detail and things don't end up exactly the same. One of the plus sides to that is they can also alter their crowns a little bit more easily than NuSmile can. So NuSmile would have to create a new mold to make a new crown, whereas another company can just change the way that they mill those crowns and they can adjust things a little bit easier. But in general, just more detail with the injection molding technique. So I talked about the intaglio surface. Here's kind of a close-up detailed view of the intaglio surface. And excuse me really quickly, I'd have to mention, I have a foster dog here. He's a little bit of a yipper. So if you hear some yips, he's working on his yipping right now. So he's just saying hello to everybody, I think. But we talk about the intaglio surface here. You can kind of see that mimic sandblasted surface there. So when you do that injection molding, you can get all those little details. Whereas with the burr, there's no way a burr can create those same details on an intaglio surface. So the benefit of a sandblasted surface is going to be that you're going to maximize that surface area. And that's really what we're looking for when we're bonding a crown is the more surface area we can bond to, the better that bond strength is going to be. You're going to get more mechanical retention, and then you're going to have less compromise to the intaglio surface of that crown as well, which I'll show you some interior views of these crowns as well. So comparing to the competitors, you got that really thin margin, whereas as you move through and you look at the competitors, you got thicker and thicker margins as you go across to the right side there. You can also see those little retention grooves in some of the competitors' crowns that we can see as well. And that can compromise the strength of a crown. So when we learned in biomaterials class back in dental school, remember, we want to have a uniform surface of any material that we're working with. Any discrepancies or inconsistencies in that surface could lead to weakening of that material. So as you see all those little retention grooves that they have on the intaglio surface, we can imagine that as you get thinner and thicker and thinner and thicker, there is some compromise to the material, which can lead to a little bit less strength. Whereas NuSmile, because it's injection molded, you have a uniform thickness throughout the entire crown, which adds to that strength. We'll compare the marginal adaptation too as well. So you can kind of see on the NuSmile ZR, a really nice emergence profile. What we're trying to do is mimic what's biologically there. You know, when we're doing a crown, when we're doing anything in dentistry, we're trying to mimic what was there naturally. So if you get a really nice emergence profile out of the sulcus, you're going to get a nice tissue response. And if you look, some of these are a little less biologic, right? You got a little more flaring towards the gingival third, which is going to increase a little bit of those overhangs and plaque retention potentially. And it just doesn't quite mimic what was naturally there. So I really like New Smile crowns because of that. It leads to a little bit more difficult prep, which we'll talk about because we have to really narrow that cervical third in order for that to drop into the sulcus. Whereas some of the other competitors, the prep might be a little bit more simple because you have that flaring and you can drop it onto the tooth easier, but we don't get the exact same emergence profile as we do with a ZR crown. And you can see a good representation of that here, whereas you know, you have the competitor dropping into the sulcus, you've got a little bit of blanching of the gingiva, whereas on that same exact tooth, you see the New Smile there not causing any blanching because it's mimicking what's naturally there. You're getting a better emergence profile and you're not getting that blanching there that you see on the left side. Maybe not the end of the world because we probably get some blanching with most of our stainless steel crowns as well, and the body acclimates to it well. But if I'm really trying to mimic what was there, New Smile crown does that a little bit better than the competitors. And you can see on this photo here, if we're going to get an avulsion, which is what happened on that left side, I'd much rather, you know, take a look at that and see what we can learn from it. So we got an avulsed tooth on the left side. You can see how that mimics the emergence profile of a natural tooth. We got a really nice tight margin. And then we have this exfoliated molar on the right side. And you can see how tight that margin is. With a 0.2 millimeter margin, you can really drop that crown into the sulcus and keep a really nice tight fit. So it's always good, you know, if you have the chance to learn from something, we don't want avulsed teeth. But it's always good to take a look and see if we can learn from it. And here's a study that kind of compares and contrasts New Smile ZR crowns and stainless steel crowns. We're not going to talk a bunch about posterior today because this is more of an introductory talk. So we don't want to get too off into the weeds. We'll talk about more interior restorations tonight. But this was a study done out of San Antonio. I think this was a 4-year prospective study. I believe the 3rd year has come out, maybe the 4th year as well. But this was back around the 2nd year, the 24-month recall. They had 36 New Smile and 34 stainless steel crowns. And their conclusion was that the results indicated that the primary molar crowns, the ZR crowns, performed similarly to a stainless steel crown, which is great. You know, a lot of the concern was that we're going to get D-bonds and they're not going to be quite as good as a stainless steel crown. But we have research backing up that these restorations do work as well, and they're excellent long-term. So we talked about New Smile Tri-N crowns and how the injection molding allows for us to have the same exact crown over and over again. So because of that, we can do a Tri-N system. And some people wonder why we want to do a Tri-N crown. Why do we want to throw in an extra crown into the kit? But I think it does make things easier. I've tried it without and I've tried it with. And for me, a Tri-N crown just makes a lot of sense. When we're using zirconia, we want to avoid saliva and blood contamination, not only because we have to clean that blood out, but also because there's phosphate groups in saliva and blood that can adhere to the zirconia and reduce our bond strength. Our general dentist colleagues, whenever they get a crown back from the lab, they only get 1 crown. So they try that crown on, they get blood and saliva on it, and then they have to clean that intaglio surface. A lot of them use sandblasting and other techniques, but us, we don't have that. We don't have the ability to sandblast. Our kiddos are in the chair and we have a limited amount of time. So the beauty of these restorations or these Tri-N crowns is that we can try them in, get them contaminated, get them bloody, set them aside, get the final crown with cement and put that thing right on. So we don't have to worry about the contamination. So it avoids those extra steps. The times where I haven't had the Tri-N crowns, I have to hand that crown back to my assistant. They have to get all the blood out. We have all those little imperfections on the intaglio surface, which is what we want, but that makes it even harder to get blood out, right? And if you have, you know, some of those competitors with those retention grooves, that makes removing blood, you know, even that much harder. So if we don't have to do that, that's even better. They're autoclavable. The white crowns, we don't necessarily want to autoclave because we can get some shade changes over time on the 3rd, 4th, and 5th times through an autoclave. There are some noticeable changes that you can see with the white crowns. Whereas if you do the pink crowns, no big deal. We don't care if they change in shade at all. We're just using them for Tri-Ns. They're quick and easy to use, which is part of the argument that some people make. Like, do we really want to be having multiple crowns getting passed back and forth? But if you think about it, and we don't have to clean the intaglio surface, we're actually saving ourselves quite a bit of time by just using a Tri-N crown. And it ensures successful results. Like I mentioned, those phosphate groups, that contamination that can end up on the intaglio, We don't want that because it's going to reduce our bond strength. And then we're going to have debonds and we're going to have recements and those limited exams that throw your day off in the middle of the day when you're already busy. So anything we can do to make our restorations last longer and be more, and be more successful, I think is always a good thing. The other thing that I will mention at the bottom here, these trying crowns are only $8. Whereas I mentioned earlier, the zirconia crowns, the white crowns are $27.50. So if we have an under-prep tooth, zirconia is incredibly strong compressively, but expansilely, they're not as strong. So if you force a zirconia crown onto an under-prep tooth, you're going to run the potential of fracturing that crown. And I'd much rather fracture an $8 crown than a $27.50 crown. So break these crowns, don't break those crowns. These are much cheaper. So if you break one of these, no big deal. I did mention that you can clean the intaglio surface by sandblasting. You can also clean the intaglio surface with IvoClean, which is that extra step I was talking to you about when I handed these crowns back to my assistant. The downside to IvoClean is A, it takes some time, and B, each of these bottles is about $40. So if you're working out of multiple ops, ideally you'd want to have one of these in every operatory. So that's just more overhead, more things to keep track of, and more cost. So trying crowns, for all those reasons, I really, really encourage you guys to try the trying crowns. They really are excellent. So here's a comparison of different ways of removing contaminants from the intaglio surface. You can see water and alcohol there. They don't really get your bond strength back because it doesn't remove those phosphate groups that I talked about. So the best ways to get that bond strength back is by sandblasting, which, like I said, most of us aren't doing. We don't have time to do that. We don't have sandblasters in our office, or using IvoClean, which costs money and takes time. So my suggestion is avoid all of that. Just use the trying crowns, and then we don't have to worry about it at all. And here's the trying crowns in action. You can see they're pink. They stand out in your kit, so you'll be able to grab them, no big deal. Try them on, and once you know your crown sizes and you know everything fits together, set those aside. Have your assistants fill up the white crowns with cement, pop them right on the teeth because we know they're exactly the same, and then we're good to go. So we talked about controlling hemorrhage as well, how important that is with zirconia restorations. And there's all different types of ways to control hemorrhage. We're going to get hemorrhage no matter what because we have to go subgingival on the prep. So there's no way we're going to avoid hemorrhage. There's going to be bleeding. It's a given. We have to be okay with that. But then we have to be ready to make it stop. So there are different ways to do it. We can do pressure, or we can move to another area. So a lot of us do in general anesthesia cases. You can prep the anterior first, go back, do your posterior restorations, and by the time you come back, our hemorrhage should be kind of slowing up by that point. The downside to pressure, which I don't really love, is that it closes that sulcus. So if you're pushing on the sulcus against the tooth, eventually we're going to want to seat that crown into that sulcus. So if you get clotting while it's holding that tissue against your tooth, you're going to have to pull that sulcus back open later on, maybe restart that hemorrhaging again, and then get it back under control. So I don't love pressure. It does work, but I don't love it because it makes placing the restoration a little bit more difficult in the end. Superoxyl, ferric sulfate, hydrogen peroxide. Ferric sulfate, downside to that, it's going to turn everything kind of brown and leave some staining on the gums. Superoxyl and hydrogen peroxide, I haven't tried them myself. I've heard that they work okay, but that's not something I'm familiar with a whole lot. Retraction cord. If any of you guys place retraction cord, God bless you. That would be amazing if our kiddos would let us do that, but I don't think that's something that most of us are able to do. This is the one I do, interpapillary injection of vasoconstrictor, which is a fancy way of saying placing more local anesthesia. So after I prep the teeth, once I do my trying crowns, I'll take my local anesthetic and I'm just going to inject into those papilla, blanch them a little bit. I'm not so much concerned about the epinephrine doing its thing. I'm really just trying to get some fluid into those soft tissue areas to kind of slow down the bleeding and allow me to place my restoration. So it buys me a little bit of time. That's all I need to get that restoration on and beat the blood to the tooth. That's really all we're trying to do. And then you can do viscostat clear as well, kind of like ferric sulfate, just without the staining. The only downside I foresee with using something like that is that when we're using our cements, we're counting on the dentinal tubules to give us our bond strength. And anything that we add to the surface of the tooth, theoretically, it could block some dentinal tubules and potentially affect our retention. So I try to stay away from extra stuff being applied to the tooth surface. I really just want dentinal tubules available. So what to use for cementation? There's all types of cements out there. We can use a resin-modified glass ionomer, a regular glass ionomer, and then we'll talk a little bit about biocem in particular, which is what I like to use for zirconia. So we'll go into a little more detail on that. But I use, I love resin modified glass ionomer for all of my other restorations. I use Fuji Sem 2 for my stainless steel crowns, from all my space maintainers, my veneered crowns, and it will work for zirconia as well. But in general, typically we just want to know what kind of cement we're using, and know how it works, know what our working time is, our setting time, and know what kind of retention strength we're getting. There's no wrong answer to cements. It's really just, making sure we understand how they work and what we're going to get out of them. So glass ionomer, that's kind of like our Keytac Sem, our powder liquid. They also have the little triturated version. The downside to that is you don't get quite as much retention with that cement. It's not super recommended. I wouldn't say that's your number one choice for zirconia, because zirconia is going to be 100% cement retained. We'll talk about that here in a little bit, but you want a passive fit for zirconia. You don't want these, snapping on like we would want a stainless steel crown, or fitting really tightly, because you run the risk of fracturing that restoration. So when we're talking about a fully cement retained restoration, we want to get the most strength that we can. And glass ionomer doesn't really provide that. It's about 10 kilograms of retention or less. And that, to me, probably isn't enough. I do know people who use it and it works for them, so I'm not telling you it's out of the question. It's just not my go-to. Resin modified glass ionomers, that's like our Fuji Sem 2s, those types of those types of cements. I know Reliax has Reliax luting. That's the same type of cement as well. You get about 15 kilograms of retention, and I have used it in the past and it's worked. There are some downsides. You have to hold those crowns on while the cement sets up. So if you have a kiddo who's getting a little squirrely and is ready to get out of there, sometimes you kind of have to ride along with them while that cement's setting up, and that can kind of create some, rotations and cants and things of your crowns while you're waiting for that cement to set up. Resin cement, very, very strong. Our patients aren't the best resin cement types of patients because we have to keep things isolated. We have to etch and bond. That's more for our general dentist friends. But if we could use resin cement, that would be a really good option. Or biosem, which I just mentioned. So get the same type of bond strength that we get with a resin cement, but a little bit more forgiving, and it's bioactive. So we'll talk about the bioactivity of this cement as well. One note that I would like y'all to remember is that whenever we're using a cement with the word resin in it, resin modified glass ionomer, resin cement, biosem would fall into kind of like the quasi RMGI cement. We want to be careful when we're using eugenol-based pulp medicaments. So that's like your zinc oxide eugenol, things like that, if we're doing pulp therapy. Because eugenol, if we remember way back in biomaterials class, eugenol can affect the polymerization of our resin in the resin cements. So eugenol is not always a good friend of resin. So if we have a lot of eugenol available on the surface of the tooth, we could get some reduced polymerization of our cement. So be mindful of that. A little lingual access on a anterior probably isn't going to make a big difference. But if you can cover that up with something that's non-eugenol based, like a neoliner, glass ionomer, tempet, anything like that, any kind of material you have, that can limit the effect that eugenol can have on the cement. So we'll talk a little bit more detail about the instructions or how to use biosem. There are a couple little differences from what you may be used to. So you want to just dispense it into the crown. You want to get a little bit of a cement collar. So if you see in that photo how that little bit of excess is coming out, we want a little collar of cement because that tells us that we don't have any voids. That makes sure that we have that entire intaglio surface of the crown covered with cement. We got the entire surface of the tooth having cement, so that we know we're not going to have voids in that area. Then we want to let it sit for about 10 to 20 seconds. So for me, this is when I'm correcting any cants, rotations, anything on the crown that I want to get straightened out. That's my 10 to 20 seconds. So we don't really need to sit there and count. Most of us are going to be doing little corrections along the way anyway, but that allows that bioactivity to start. The longer that cement can sit on the surface of the tooth, the longer it has time to penetrate those dentinal tubules and begin that process of bioactivity. And then we can tack cure this. That's the beauty of biosem, is it's resin. It's a light cured resin material. So we can it also will self-cure, but that light curing ability can help us tack those crowns into place and get them exactly where we want them. So what I'll usually do is I'll get them exactly where I want them. I kind of use the tips of my fingernails. That way I'm not covering up the incisal edge to where I can't see the rotation or cant of that crown. And then I'll have my assistant come in with the light, give it about 2 to 3 seconds of a light cure, kind of get that material rubbery along the gingival margin, and then I can peel it right off. That's one of the beauties of this biosem material. And test your light with it, because some lights will take a little bit more time than others. So at that point, we're going to hold on to the crown. We don't want to displace it because we've started some polymerization. We're going to clean off that gingival third, get all that excess cement out. And then we'll allow that to take 60 seconds. You know, cleaning up the excess cement usually takes 60 seconds anyway. But if we're doing it quickly, we may want to give it a few more seconds to let that bioactivity continue to penetrate those dentinal tubules. And then we give it a final cure, about 10 seconds on the facial and lingual surfaces. And there's the hydroxyapatite formation that you can see on a scanning electron microscope there. One thing to keep in mind is that once it's cured, it's cured. So we can't move these crowns after we've locked them in place. And you can kind of see there where I learned a little lesson on keeping those crowns in the right spot. Pulled off my finger and I said, oh, darn it, we kind of made that rotated and you know, now we're kind of set. But always keep in mind that once you cure these crowns, we can't really move them again. We have to be mindful of that.
Dr. Lucero, just letting you know, just giving you a time update. We've got about 9 minutes. So
okay, cool. Well, we'll keep cruising along. I knew this was going to be quick, so we'll do what we can here, guys. Case selection, we'll kind of cruise through this. We just want to use these anytime we use any other type of crown. The one thing to keep in mind is that if we have severe crowding, we have to be mindful of that. Zirconia, we can't squeeze, we can't adjust like we can a stainless steel crown. So just be mindful, you know, if it's a severely crowded case or if we have a lot of space loss, prepare those parents to know like, hey, we may not be able to do zirconia and give yourself an out. Don't overback yourself into a corner where, you know, you feel like you're stuck doing zirconia if it's not going to happen. Make sure you have adequate clinical crown. We need something to cement, something to hold onto that crown. We need to be able to control hemorrhage. And in general, we just need a cooperative patient. Don't do this on a questionable patient. If you want to start out with like GA cases, I always think that's a good idea too, just so you have plenty of time, you're not rushed, and you're not under any pressure. One thing to keep in mind, you don't have to do pulpotomies when you do zirconia. That was kind of an early thought because people were getting a lot of failures, and I think it was because people were over prepping a bit. So you were seeing a lot of failures from necrosis of the pulp and things like that. We don't necessarily have to do a pulp just because we're doing a zirconia. Really, a pulp therapy is indicated only if the caries dictates it. So if you have decay to the pulp, do a pulpotomy. If you don't have decay to the pulp, you don't have to do a pulpotomy. Treat them just like you would any other tooth. Continual diagnosis as you go along, of course, just like we do on any other restoration. So here's the anterior express prep technique. We'll go through this step by step. If you want to take a quick screenshot of this, feel free to. New Smile will always email you a copy of this as well in a PDF format too. So this is just a good reference if you ever want to look back and remind yourself of some of these steps. There's 3 burrs in the New Smile kit. You can use any burrs you want. I use similar burrs, not the exact same kit, but if you come to a restore course, this is the kit we have. The step 1 is going to be some incisal reduction. So 1 millimeter reduction of the incisal edge. Then you go ahead and flatten that off. The second step are going to be some depth cuts on the facial surface. You can do 2 or 3, however many you need, depending on the size of the tooth and what you feel is appropriate. Try to keep that at the gingival third if you can. That way, when you do this next step, you're going to be right at the gingival margin. So you're going to do an interproximal slice, also about 1 millimeter or so. If you under prep here, this is when you're going to get a lot of under prepping overall, where your slices were too narrow. Then at the end, you go to try your crown on and you're under prep. So make sure you use about a full millimeter interproximal slice here. Then you're going to connect all of those depth cuts into kind of a shoulder all the way around. And if you see on this example, it's not quite as low as I would ideally go. Try to keep it right at the gingival margin so that when you do this next step, which is a super gingival try-in, you can get that crown all the way down and make sure that you're reduced enough. On the lingual, now we're going to take that football burr and we're going to reduce that cingulum. And you really want to keep your reduction in this area here in the gingival third. Try not to go too much up onto the concavity of the lingual surface. Otherwise, you're really going to thin out the incisal edge. So you want to keep that down in the gingival third at the cingulum there. Then we'll do a super gingival try-in that I mentioned. So you take that pink crown, you try it on, seat that to the gingival margin, and you should have a little bit of rotation, a little bit of movement on that crown. If you're locked on, that means you're under prepped, and that's when you can fracture a zirconia. Then we'll take our thin diamond burr, drop it down about 1.5 millimeters subgingivally, and we're going to remove that entire shoulder and give ourselves a feather edge circumferentially there. One thing you want to keep in mind here is keep that burr vertical with the long axis of the tooth. Keep those two things parallel. That way you're not leaning the burr in and creating kind of like a TP type prep, which we don't want to do. That's when we can bring those pulp horns into play and get one of those failures that I talked about earlier with over reducing. You really want to make sure that you're keeping your circumferential reduction in that gingival third, because that's where those crowns are going to drop down into your sulcus. Then we'll do a final try-in. This crown should drop subgingivally, and you should have a little bit of movement, a little bit of slight rotation on the tooth, telling you that you're not locked onto the tooth and that you're not going to fracture your final zirconia crown. And you should have a little bit of rotation here, just a little bit of wiggle. That's all you need. So good rule for try-ins, if they're tipping, if you're getting a mesiodistal tip, kind of like this, that means that you're under reduced on your facial or lingual. So I always say, like, where are you creating a hinge, right? Where is that crown hinging on the tooth? So then go back and reduce on the facial or lingual. If you're getting a facial lingual tip when you try on that crown, that means probably on the mesial or distal you're under reduced, and that's where we need to focus on our reduction in order for that crown to drop on and quit rotating or tipping on you. This is what happens if you under reduce, you get a fracture. So this was a different crown done by another provider. Kiddo came in, we just replaced it, but that's what can happen. You under reduce, they fracture, and that's kind of what they look like. So I'm going to walk through a quick case here, start to finish. This is one I did last week, so I just wanted to record it so I can walk through it with you guys. Number one, try on your get your try-in crown, hold it edge to edge with the existing teeth so you know which size you want to go with, and that's kind of what I stick with all the way. If it's an A2, that's what I'm going to go for. That way we know what we're trying to aim for there. So there's our depth cuts on the facial, and I do all these steps kind of in one step here. We're going to do our depth cuts on the facial, our interproximal slices, and our connection of all those depth cuts and slices, all kind of in one movement here. So we're going to take that burr, and now we're going to start connecting everything together. And this is what's going to create that shoulder on the facial and interproximal surfaces. And we're just going to smooth all that out. We want to get rid of those depth cuts, get everything back smooth again, and then we know that we have enough reduction circumferentially there. We're going to do the same thing on the central.
Matt, Dr. Lucero, I was going to say, you might want to turn your camera off. Just it's lagging a little bit. See if that maybe will.
Oh, okay, sure.
It up just while you're playing the video.
Let me see if I can turn this off real quick. Let me see if I can. Sorry about this, pup. These Fosters, man, I'm telling you.
He's all right. I don't hear him, so it's all right.
I don't know if I can. Let me see if I can shut the camera off here.
And it's okay if it's not. It's going. It's just a little slow.
All right, I apologize, guys.
Yeah.
So yeah, we're going to connect all those depth cuts. So this is the central here. I'm going to skip the other two teeth. So we edited those out because it's just the same thing over again. So connect all those depth cuts, connect those slices together interproximally, and we should have a nice little shoulder about 3/4 of the way around the tooth. That's what it should look like up close. Now we'll take that football burr. We're going to go to the lingual surface, and we're just going to remove the cingulum. So you can tell here, if you look in my mirror, you're seeing I'm just on the cingulum there. I'm not going up into the concavity of the lingual surface. We're just going to flatten that cingulum. And if it's a big cingulum, you might need a little bit more reduction. If it's a little cingulum, maybe not quite as much reduction. We're just going to flatten that thing off there. And we're just kind of blending it into that slice that we did interproximally as well. And this is our supragingival try-in. Take our crown that we tried out at the beginning that we know is the size we're trying to get to. Seat that down to that shoulder that we created, and we should have a little bit of movement. That just tells you that we're not binding and that our tooth isn't under reduced. Now we'll take that subgingival little flame burr, drop that down into the sulcus, and we're going to remove that entire shoulder. So we're going to create a feather edge all the way around the tooth. And at this step, we're going to go 360 degrees. So we're going to let that go all the way around, create a feather edge, and make everything nice and smooth. And I like to use my burr kind of like an explorer here. I'll kind of go up and down with the burr, make sure that I don't have anything down there that I can't see. And that helps me feel if there's any imperfections or any bit of that shoulder remaining. And you can see here, we're going to create a little bit of bleeding. There's no way to avoid bleeding. It's going to happen. But we're going to take care of that at this next step when we stop the hemorrhage in order to cement. One other thing I like to mention here is take care of the soft tissue. Try not to damage the papilla. Papillas look really nice post-operatively. If you have black triangles, parents are already a little bit nervous when these kiddos are getting treatment. And the more aesthetic and the more nice we can make the final appearance of the case, it always relieves the stress a little bit of parents. So I really try to limit the amount of trauma. That also creates a better environment for me to stop the bleeding at the end. So just be really gentle to those papilla. You can see how that crown drops into the sulcus there. We got a little bit of movement, just a little bit of rotation. And you can see on this tooth here, I didn't quite get it dropping into the sulcus, so I'll just take my explorer, tease that soft tissue up just a little bit. That way my crown drops in. And you can see we got a little bit of movement. Just that little bit of rotation is all we need to know that we're not locked onto that tooth and we're not going to fracture our crown. We'll take our local anesthesia and we'll blanch that papilla. You can see all I'm doing is trying to get a light blanch, and that'll slow down the bleeding enough for me to get these crowns cemented without any bleeding or contamination present. In the meantime, you can see I did some pulpotomies. We edited those out. But we did do pulpotomies on 3 of those 4 teeth. So now we got our bleeding stop. You see just a little bit of light bleeding. Just take your air water and blow that away. Really, all we have to do is beat the blood to the tooth with our crowns when we're cementing them. So drop that in. I'm just going to make sure that the gingiva is over the crown so that we're dropped into the sulcus. You see that little bit of excess cement coming out there? That means that we don't have any voids. Take your time at this step as well. You don't need to rush. So you can see I just take my air again, I blow that excess away. And then we'll take our Explorer one more time so that our crown drops into the sulcus. And then we'll tack cure it in place. And we just want to give it a few seconds. Test your light out with the cement too, so you know how many seconds it'll take to get a nice rubbery consistency of that cement so that it peels off easily. Do the facial and the lingual, quick tack cure. You can see here it's a little bit runny still, so I went back with the light and gave it one more quick tack so that it'll come off in one piece. So again, take your time, don't rush through this. You have plenty of working time with this cement. So we go back in, now it just kind of peels off. And you can see how nicely it cleans up. Really, really nice, easy peel. I keep my finger pressured down on the crown so that we're not moving it, we're not displacing it and disturbing that polymerization that's already happened. And then on the lingual here, you'll see I kind of pull the cement out of the interproximal area so that we get all of that excess cement from between the crowns as well. Nice and easy, highly polished surface so it's not sticking to the crown. And it all peels out there. Then we'll do our laterals, and I like to do the centrals first because I'm really concerned about the midline. That's my main concern, is making sure my midline is on and that I don't have any cants of those crowns. So I always do the centrals first, and then I'll come back and do my laterals after that. Tease the tissue over the crown, nice and gentle, and then we'll tack cure that in place. We'll clean up the excess after that, and then we'll do our final cure here. But you can see how nicely this cement handles, especially on a highly polished surface like these zirconia crowns have. The cleanup is really easy. The beauty is you lock these crowns on right where you want them. You're not holding on to that cement while it's setting up. Nothing's moving on you, and you get a really nice result. So we'll go back in, we'll clean up that excess there. Comes off nice and easily. And then my assistant comes in right after this, gives it a nice long cure, 10 seconds facial and lingual on each tooth. And that's the whole process. You get a really nice result. You can see the tissue looks beautiful immediately post-op even. We're not more than 2 minutes after the procedure and everything looks amazing. So really simple process once you break it down into manageable sections, and you get a really, really beautiful response. So here's a couple cases. This is an asymmetric case I did a couple years ago. You can see how well the tissue healed up. But that's the beauty of zirconia, is you can do asymmetric cases and you don't notice the difference. If you were to do a veneered crown on this, you're going to see a big difference between the right side and the left side, whereas zirconia blends in really, really beautifully. Here's a case I did for my assistant a couple weeks ago for her daughter. She sent me this photo a couple weeks later. Tissue looks beautiful. This was also kind of the works type of case. We did Bioflex on the posterior, so you can see how nice that looks as well. This was a case I did a while back where we did lower incisors also. So you can see NOP and Q were zirconia as well. We'll get into that maybe at a future talk when we do a little bit more mastering zirconia. And here's a case with SDF. A lot of people get nervous with SDF and zirconia. They think it'll show through, but really if you prep the tooth the way we need to with zirconia, you get through a lot of that darkness anyway, and it's not going to show through your zirconia restoration. Final tips and tricks here with zirconia. Make sure you have a game plan for hemostasis. Prepping the tooth and being gentle to the tissue is number one. And then just making sure you go in there and stop that hemorrhage quick enough that you can get the crown on. If the crowns aren't seating, you need to prep in the gingival third, not the incisal third, so you don't bring the pulp into play. Only pulp the tooth if you really need to, if the caries dictates it. Use a little bit of excess cement so you get that cement collar that we talked about. And then make sure you take your time when you're seating your crowns. Make sure you get the alignment where you want it before you tack cure. That way you don't have a tooth that's misaligned and then you can't go back and correct it. And the main thing here, prepare guardians too. If you don't think you can do a zirconia crown, or if you have any question whether you can or not, give yourself an out. Tell them, hey, we'll try to do it. If we can't, then we have plan B. Make sure they're on board with that plan B. And if you need to fall back on it, no big deal. We've talked about it. Everyone's on the same page and no big deal. And thanks all for watching. I appreciate you taking time out of your busy weeknight. I apologize for this foster dog. He's really cute. If you saw my Instagram, he's an incredibly cute dog. But man, it's hard to get him under control. He's a wild man. So I apologize for the background noise.
Very good. No worries.
Cool. Yeah. And if you want to reach out, you can email me. You can reach out to me on Instagram. We're going to do some mastering zirconia in April. So if you want to take a shot of that QR code, we'll be doing that course in April.
Okay. Yeah, well, thanks, Dr. Lucero. Yeah, really, the pup wasn't bad at all. So you're good. I had a little then he jumped up.
I even gave him a trazodone, guys. I did my best here. He's a wild man. I apologize.
That's awesome. Well, I'm gonna, before opening up to questioning, just so it's 8 o'clock. I'll give it about 5 more minutes if we have any additional questions. But I did want to go over briefly again on how to retrieve your CE. If you didn't hear me a little bit earlier, once we complete this webinar this evening, our events team will send an email out to everyone that attended the webinar and with a survey. Once you complete the survey and send it back to us, the events team will then send you your CE. Just please double check your spam folder. A lot of times it does end up in the spam folder, and then give us mostly till the end of the day tomorrow to receive it. So if you don't receive it directly in the morning, just hang tight to usually the end of day tomorrow. You should receive it. If you have any issues whatsoever, once again, you can reach out to myself, Preston, the North American sales manager, or anyone in our events team, and they'll be able to help you out. As far as questions, we have a few, but it looks like most of them are already answered. I'm going to read through them, Dr. Lucero, just a few of them,
Cool.
but like I said, most of them already
were
you answered them. So,
cool.
First 3 I have are, why do they break during try-in if they're so strong? And then I'm going to read these 3. And then what do you like to use to control heme? And will SDF show through? Like I know most of you just answered that, but if you want to.
Yeah, we got that right at the end. Yeah.
Yeah.
So they fracture. So zirconia is an incredibly strong material in compressive strength. So, all materials have different types of strength, right? We have, expansile strength, we have shear strength, we have compressive strength. Zirconia is incredibly strong with compressile strength. So if you're compressing it, it doesn't fracture, it doesn't break, unless you put an incredibly heavy load on it. Whereas like expansile strength, not quite as strong. So if you're forcing it onto an underprep tooth, you're going to expand that material, and that's when it breaks more easily. So that's why it's so important to make sure that you have a passive fit. That's why we check to make sure they're a little bit mobile on the tooth before we cement. If you have it locked on and then you really force it down, that's when you're going to get those little fractures. And then the SDF we talked about. Typically, you're not going to see the SDF through the crown. Once you do your full reduction of the tooth, SDF doesn't penetrate that far into the tooth. So a lot of times you're going to reduce that color or that discoloration out of the tooth to begin with. If you do have a little bit of residual staining, you can use something like neoliner or some type of kind of liner material that's white or opaque, and you'll be able to block that remaining little bit. Just put a thin layer of that down before you cement if you're worried about any show through. But typically that's not something we run into. That's pretty easily managed just by prepping the tooth.
Well, yeah, with that, I think we're going to conclude the webinar. Once again, thank you, Dr. Lucero, for joining us and giving us this presentation. For everyone that attended, try to join us on April 17th for our Masters Zirconia, where we'll get way more in depth and touch a little bit more on posterior as well. And if you have any other questions, feel free to reach out to myself. Once again, my name is Preston Fontenot. I'm the North American Sales Manager. Other than that, we're going to call it an evening. Thank y'all very much.
Thanks for watching.